All right. Well, thank you again for being here. We're going to go ahead and get started. I will be introducing each speaker. They'll present for 15 minutes, and then David will jump in with the Q&A. So first and foremost, I am going to introduce Dr. Bill Tapp. Dr. Tapp has been a generous partner to the EHE Foundation, providing his time and guidance. He is the lead clinician on our Chan Zuckerberg Initiative grant, and we appreciate his time and support. Dr. Tapp is at Memorial Sloan Kettering Cancer Center, and he will be providing us an overview of the EHE Center of Expertise at MSK today. So please welcome Dr. Tapp.
An honor to be here today, and I want to thank you and the collective EHE Foundations bringing us together. And I think these can be some of the most important conferences we as clinicians do, because it brings together families, patient caregivers, and medical staff to really understand this disease and figure out how we can best affect patient care. And along those lines, I thought it would be nice to start off the conference by talking about some important themes that I hope we will be able to tackle over the next few days through the conference. And in such, I wanted to talk a little bit about the efforts that we're having at MSK to establish an EHE Center of Excellence. And I think this really started from our first introductions to patients with EHE. And I think anyone who is involved in EHE from a care level, be it patients, patient family advocacy groups, and definitely clinicians, is that you can really be struck by the difficult course that patients go through. And a lot of this has to do with the disease itself. But often patients spend a lot of time kind of circulating back amongst care providers before an actual care plan is given. And that can really delay diagnoses and allow for disease progression. And one of the things that can take some time is really trying to bring the patient, the caregivers, and the clinical care team on a unified path where we can actually move forward and affect the course of their disease. And I think that understanding is critical. What is compounded, or what compounds this, is actually several facts. One, this is a really rare disease, and it's a very heterogeneous disease. So there's tremendous variability in what patients go through, not only due to the type of the disease, but where it's actually affecting them. And so it's very important to try to figure out what are the individual treatment strategies for patients. And this can be a very challenging thing, again, when you think about such a rare disease, and it definitely requires the involvement of a dedicated community such as this. Clearly, as we always preach, one of the most important things is for a patient with EHE to be surrounded by a disease management team that is familiar with the disease. And generally, that is within a sarcoma DMT. Again, the DMT is the disease management team, and often the sarcoma medical oncologist is the one that can really spearhead the care for the patient. And in doing so, we also have, fortunately, the involvement of other experts that we often have within the sarcoma DMT, our musculoskeletal pathologists, radiologists, surgical and orthopedic oncologists, and radiation oncologists. And creating this unit around the patient is critical. Importantly, there has to be close communication with the patient's primary care physicians, and often local oncologists, because patients have to come to tertiary care centers. But when we think about EHE, there has to be an extended team that is also familiar with this disease to really be able to appropriately care for patients. And when we just think about some of the other care providers, they can range from hepatologists to pain and palliative care specialists, clinical trialists, interventional radiologists, and pulmonologists. And what's critical is coming up with this extended care team, again, that is really familiar with the nuances of the different journeys that patients with EHE go through, right? And this is critical. Now, to take this one step further, this is really just the oncological-based teams that we need to have around a patient to really make sure that we can offer appropriate care. In addition to this, we'll talk a lot during the conference about the different types of clinical and basic science research programs that are needed. But when you think about a journey of a patient with EHE, you also can think about all of the unique psychosocial stressors that a patient can go through. So we really need to be able to understand the unique aspects of EHE, how it affects a patient, how it affects a patient's family and caregivers. And then again, how do we individualize this where we can actually address all of these different needs as they arise so we can allow for holistic and longitudinal care. And this was one of the discussions early on at Memorial Sloan Kettering, where we felt that we really needed to organize this so we can actually organize this specialized team approach to be able to work with patients with EHE to actually help with their care. And we set out to actually form a focused international center of expertise. And this was really going to try to create our infrastructure and our expertise and familiarity with the disease, right? And that was the initial aspect of this. And what we wanted to do was institute a focused multidisciplinary EHE team so we can actually create that broad expertise specific to EHE, again, age agnostic. And we wanted to be able to have every case discussed in this multidisciplinary care team. So not only the medical providers, but all of the specialty services and supportive services that a patient may need. And in doing so, we also wanted to help develop EHE specific guidelines at Memorial to provide for longitudinal and holistic care strategies for our patients, and then also be able to interact with the community. Important to this was beginning to define the different type of clinical and pathological presentations and subsets that we see with patients, because it's such variability in how this disease presents and what it does to patients, and then again their clinical course, right? And we have to be able to tailor our treatment paradigms based on the type of disease that a patient has and what they go through. And so this was required the combination of understanding clinical data sets and also pathological data sets. In addition, as we did this, we wanted to ramp up what we would be able to do from a research standpoint. And we felt it was very critical to understand EHE from a pathological level, how the different presentations happen within the body and what that means clinically. And Dr. Antonescu will talk a little bit about this within the next presentation. And then the last thing that we wanted to do was really begin to develop collaborative research portfolios, tapping into some of the strong program project areas that we have in sarcoma and in other diseases at Memorial, build our clinical trial infrastructure around this. But importantly, as we did this, we felt all of this needs to be collaborative. So meetings like this are critical because every program needs to have a conduit where they can actually collaborate, share their work, learn from others' work, and create a collective moving forward. So this is our foundation at Memorial Sloan Kettering. And just as an example, one of the things that we're trying to do is to include EHE into some of the infrastructures that we already have. So we have a very large sarcoma immuno-oncology program. And every clinical trial that we have is based on ongoing research where we're trying to understand the different facets of the immune mesenchymal environment in sarcoma, as well as we do clinical trials to take data back into that clinical research we're doing to better understand response patterns that we're seeing and to better understand how to apply various treatments to our patients. And oftentimes, this requires a lot of correlative work in some of the trials that we do where we can get pre-treatment serum samples, pre-treatment tumor samples. We're able to offer unique treatments for our patients and then be able to analyze not only the outcomes data, but also understand what's happening in the body so we can better tailor the types of treatments we offer patients. And we're fortunate by having this mechanism that we're able to include EHE in very specific cohorts in some upcoming trials. And I just wanted to highlight two of them. One will actually be an upfront study of gemcitabine and docetaxel with a checkpoint inhibitor in patients with advanced sarcoma. And the goal would be that if we can also include a significant number of EHE patients, we can really begin to understand not only the immune microenvironment, but also the interface between chemotherapy and immune checkpoint blockade in these patients. We also have a study that just opened, which is a phase 2 study of lenvatinib and pembrolizumab in patients with advanced soft tissue sarcoma. So again, this is a trial that will allow us to test novel therapies in some of our patients with a specific EHE cohort. And the goal is to understand the different immune microenvironments in EHE patients and understand which patients may be more responsive to therapies and which patients should actually be enrolled onto some of these clinical trials. Importantly, to do this, we not only have to take the data that we're extracting from these studies and compare it to all of the immune oncology work we're doing in sarcoma, but also compare that to the landscape analyses that we're doing in EHE specifically. And I think this is critical to really truly understand how to move treatments forward for our patients. But what is apparent is that we are just one center, and this is a diverse and rare disease, and this is something that one center cannot do alone. But we also know that many centers are doing similar types of projects. So the question is how we can begin to unify these centers so that when a patient presents, we can actually understand the heterogeneity of their disease, the course of the disease, their journey that they're going through, and then be able to apply the appropriate therapies and the appropriate research models. And in my opinion, that's what's so critical of conferences like this, where we can begin to create a central EHE collaboration, where we can take the research and the programs of institutions across the world and begin to unify our understanding and our treatment paradigms for patients. And there have been already some very nice efforts from ESMO, from CTOS, and I think the EHE Foundation and EHE 360 is going to be a critical aspect of that. We just did have a consensus meeting on EHE, which was remarkable. It was sponsored by ESMO, and it was just this January. And we discussed many of these aspects as well. What was important was to understand really the differences in understanding of this disease and treatment approaches. So how do we begin to unify this? And we spoke about what infrastructures are needed, what organizations should be involved, which academic centers are building program project areas in EHE, and then what are the specific projects that could be helpful. And I think with this conference too, we should really discuss where that collaboration lies with the patient advocacy groups and the various EHE foundations. And this can be from developing registries to working on tissue banks, preclinical models, and how we can collaborate and disseminate those and what type of clinical research and clinical trials we need. And just for the last few slides, I just wanted to show a little bit about the initial works of this. This was spearheaded by Evan Rosenbaum, who's now a faculty member at Memorial with Christina Antonescu, and they looked at our database that was generated in patients with EHE. Now, this is a single institution. We needed to look over multiple years to get a good number of patients, but we are a referral center. All of these patients had confirmed diagnosis, and importantly, we have multiple practitioners now, 14 medical oncologists alone that see EHE patients. So we're also going to have different ideas in how to approach EHE. And the hope was that we can contribute to a foundation. Now, this is clearly not the foundation, but it's just a piece of the foundation that we as a community need to develop to understand this disease. And as mentioned, this is a relatively large cohort. All were molecularly confirmed, and we tried to also include some of the rarer subsets, such as the YAP-TFE fusion. And we began to see some interesting trends with the data. Within the patients who had the YAP-TFE fusion, again, small numbers, only about 10 patients, but the majority of them were younger, so less than 50. So it's important as we get larger data sets from other institutions to see, whether or not these trends begin to hold true in our patients. So presentation-wise, most of the patients presented with disease in the lung, soft tissue, liver, or lung. There were less patients who presented with bone-only peritoneal disease. And these are important, again, to highlight those areas which we need to gather larger data sets to understand the clinical courses and appropriate treatments for these patients. We have a lot of interest in pulmonary patterns of spread. We know that there are certain types of EHT, specifically those with pleural-based disease, that can be very aggressive. Understanding these presentations, understanding how they should be diagnosed and how they should be initially treated are critical. Not only how do we treat them with oncological agents, but what are the supportive care measures that are most appropriately for patients to allow them to continue through treatment? So this is an important area of research, as are the different types of diseases that we see in liver. We tend to have diseases that can be very indolent in the liver, but also those that can have dramatic microscopic spread and infiltrative types of disease that can hurt our patients. So discerning those will also be very critical. Understanding the types of spread, the fact that EHE can go to the lymph nodes is also very important in how we diagnose and treat patients. And so these are the types of data sets that can emerge. And importantly, we were able to prognosticate a little. So it seems that patients with soft tissue primaries, unifocal disease, the YAP-TFE fusion seem to do better. Again, small numbers and need to be confirmed on larger data sets. Whereas if you have metastatic disease, pleural involvement, lymph node involvement, these may be more aggressive variants and may affect initial managements from our patients. And importantly, what we saw is that a third of our patients were initially observed, and that can be a very important treatment for our patients. A quarter underwent systemic therapy, and the rest actually were resected. And many of those patients remained free of disease. And so selecting the right patients to watch, to resect, and treat becomes critical. What I was also struck with are the different numbers of treatments that patients had. Now, not all of these were at Memorial because we are a tertiary referral center, and many of these happened at other sites and in the community. But again, you can see how there is not a unified method for our patients. And is that because we have not yet unified it, or because of the variability of the disease? And showing, again, how some of these treatments helped. But the take-home messages are broad, and what I wanted to really end with was that EHE, although genomically simple, has a very heterogeneous presentation, and we need to understand the disease so we can appropriately individualize treatments for our patients, not only from a cancer standpoint, from a psychosocial standpoint as well. We can begin to identify diseases that may need more aggressive treatments up front, but clearly this is not a one-size-fits-all type of approach for patients. So getting the community together is actually critical for this. And I'd like to end by now thanking the EHE patients and their family that have actually put us in a position to really think about their disease holistically. The EHE Foundation, Jane Gutkovich, who was instrumental in my understanding of the disease early on, and then our colleagues at Memorial that you can now see across disciplines that actually specialize in EHE and bringing their unique thoughts, views, and expertise to helping our patients. So thank you very much.
All right, Dave Casimir here. Just confirming I'm live here. Dr. Chapper, are you able to hear me? There we go.
I am, yes. Thank you.
Excellent. So I've got a question here. We got first a thank you for your presentation from the question asker. And then the question. New patients continue to be diagnosed with EHE. As you mentioned, many were initially misdiagnosed. What is your recommendation to them to advocate for themselves to help build their treatment team?
Yeah, I think there's a few things. You know, what we've found is that most local oncologists, primary care physicians, you know, they're just not familiar with EHE. So there's two things. One is how quickly can the diagnosis be established? How is the correct way to establish that diagnosis? And I mention that because sometimes there are certain aspects of EHE where we're not as akin to biopsying in certain areas, right? So a lot of thought and expertise often has to go into what is the best way to establish the diagnosis. And then once the diagnosis is established, is really working with your local doctors to be able to go to a tertiary care center where there is expertise in EHE. And often it's at those tertiary care centers that can create these more elaborate care management teams that can work closely with your local physicians, right? And I think that's critical because there's so many nuances about the disease and what a patient is going through. So the advocacy point is really, once there is concern that this could be EHE or a rare cancer, is definitely going to a tertiary care center with expertise at EHE. So you can begin to build the correct team around you and identify who in those teams should be really taking the lead, quarterbacking decisions and informing patients so the patients can be actually really involved in making those decisions as well.
Excellent, thank you. And just to note, we're getting multiple thank yous to you from the audience here. I've got a second comment that came through that's not quite a question, but I'm going to turn it into a question. I'll give you the comment first and then give you the question. They said it's somewhat of for your information, but I believe you mentioned a form of Taxol for chemo treatment, post-liver resection, and microwave ablation in December 2019, January 2020. Chemo with Taxol based on my symptoms appears to be working. The way I'm going to turn that into a question is, because we've got different people being treated in different centers around the world and people are experiencing different results with different drug or drug combinations, how are you at your center sort of evaluating what's going on around the world to enhance your own plans for what may be viable options for different types of patients?
Yeah, I think it's a great question. And for us, it really comes with the collaborative nature of our international community. And fortunately, the sarcoma community in general is very collaborative. So we're always discussing individually on conferences. And just as an example, we did have this ESMO conference where specialists from all over the world really joined, and it was an amazing event. And that's where we share data and learn. Importantly, though, when we look at that conference, there was still a lot of differences in opinion as to what can help patients or potentially doesn't help patients. For example, it was argued for some time whether or not chemotherapy can be effective in these tumors. And clearly, as the person who asked the question shows, is that there are certain chemotherapy drugs in certain patients that can be very helpful, right? So understanding how to differentiate who needs therapy and when and what type of therapy is critical. But just like was mentioned earlier, this is not something that one team can do. It really takes collaborative projects, both retrospective and prospective, to begin to understand that. And these anecdotal experiences are critical. And then the constant communication, publishing of data, discussing data, and really struggling over what is right is very important.
Thank you. A very quick question here, I think. Why is it that you think checkpoint inhibitors will work? And the quick follow-on question was, does EHE show PD-1?
Yeah, it's variable, and there's a lot of controversy in sarcoma as well, how well PD-1 could be a marker for a response. And we've actually done some studies that have shown in small numbers potentially predictive in some of the subtypes. But we also know that there's a group of patients, and not just EHE and sarcoma in general, that start off PD negative and have a very nice response to therapy. And if you look at tissue after the administration of immune checkpoint inhibitors, you can actually see a conversion into a PD positive subtype. So what does that mean we're struggling with? But generally, in all of the sarcomas, there are some that actually have nicer responses to checkpoint inhibitors or immunotherapy than others. But there's still tremendous variability in those diseases, like I would expect to see in EHE. There must be something about the immune microenvironment in EHE that potentially could allow for a response in certain patients. And I think this can harken back to some of the clues we're seeing clinically in this disease. We feel it is a very inflammatory generating disease. We also know that it can be related to certain types of autoimmune diseases. We were talking about that in the conferences. We have a high predilection of patients that may have a secondary autoimmune disease, Crohn's disease, and we're trying to understand those connections. So understanding the immune microenvironment in EHE and the surrounding tissue in general, and then understanding response patterns to immunotherapy will be critical, so we could come up with some predictive markers to understand which patients should receive immunotherapy and why. But it's still very early. All of this is very anecdotal, and we need to get more enrollment and have more clinical trials that can begin to answer the questions of immune therapy in patients.
I'm going to ask a follow-on question from someone else. It's an independent question, but it kind of relates to the point you just made. And this may be a hard one to answer, but I will ask it. What is the typical number of patients you need to be involved to sort of understand these patterns?
Yeah, it's a great question, and we struggle with this in rare diseases. One, from a funding source. One of the reasons we were able to add cohorts of EHE patients onto clinical trials was because of some generous funding from donors that allows for this research. But there's two points to that question. You know, do we have enough patients who can enroll in a trial? You know, ideally, the more patients, the better. But often in rare diseases, you know, we will try to get early signals in about 10 patients to understand if we're seeing some efficacy. Unfortunately, with the variability of the disease, you can often lose or mask efficacy signals based on random chances of what type of EHE patients or what type of disease EHE patients have on clinical trials. So it's so important also to try to perform some of these correlative experiments, be it, you know, is there a biopsy that can be done or blood that can be taken during and after therapy, because we may begin to understand the response patterns in a lower number of patients. So ideally, as we do research in all of the immuno-oncology clinical trials, we need to have patients with EHE enrolled on them that makes sense. You know, the trials I mentioned, I feel comfortable enrolling patients because we're also using drugs where we're seeing some efficacy, chemotherapy, tyrosine kinase inhibitors, checkpoint inhibitors, but we really have to begin to tease out why some patients may respond and not. And those correlative experiments, especially when we have smaller numbers, such as 10 patients or so within a given arm, may allow us to understand those response patterns. Also importantly is by starting with a small number, if you do see something promising, it's a little easier then to expand the study and say, well, maybe we can do this at more centers or get more funding or bring in, say, 30 patients to really begin to answer the question of the efficacy of these agents in our patients.
Thank you much. All right, I think we're at time here. There were a number of additional questions, but those will be available in the chat, and we will have a record of those and see if we can get them answered at some point at a later time.
Great, thank you.
Thank you again.